Hello and welcome. Thank you for joining us today. I will give folks a minute to join and we'll start promptly. For those of you joining, I'm going to give a few more seconds and we'll begin momentarily. Welcome to our 2025 Self-Direction Virtual Conference Series. My name is Ines Rosas. I'm a senior consultant at Applied Self-Direction. For my visual description, I am Latina. I have long, dark brown, curly hair, and I am wearing glasses. Today I'm wearing a green shirt. Thank you again for joining us today for the third session in our conference series, Too Big to Thrive. I'm going to run through a few housekeeping tips before we begin. Due to the volume of attendees, participant microphones have been muted and will remain muted. There is a toolbar at the bottom of the Zoom window with a few options you can use throughout the webinar. There is a React button that you can use to submit reactions or emojis. You can also submit questions and comments at any time during the session by using the Q&A button in the same toolbar at the bottom of your Zoom window. We have time reserved at the end of the session for your questions, and we will address as many of your questions as possible at the end of the session. Closed captions and translations are available for the presentation. You can access the closed captions by clicking the CC button or choosing Show Captions. This session is also being recorded and will be available on our website. The month of March is sponsored by eViro, and thank you to all our sponsors. First, we'd love to know who is in attendance today, so take a moment to answer our first poll question. I'm gonna launch it. All right, you should see the first question. We just want to see if you could describe your role with self-direction, and I'll give some time for everyone to submit their answers and end the poll, and we'll look at the top groups. So we're interested to know if you're a self-directing participant, a family or a friend, if you're a direct care worker, state staff, federal staff, FMS provider, support broker, advocate, case manager. Thank you everyone for quickly submitting your answers. It looks like our top attendees are FMS providers, state staff, and family and friends of a self-directing participant. Thank you so much for participating, and I will now turn things over to Brian O'Malley to get us started. He is the Executive Director of the Consumer Directed Personal Assistance Association of New York State and Consumer Directed Action of New York. Thanks for being here, Brian.
Thank you, Ines. Thanks for that introduction. Thank you, everyone at Applied Self-Direction, for having me. For what I think is, and hope you all find is an important and useful session here. As Ines said, my name is Brian O'Malley. I'm Executive Director at Consumer Directed Personal Assistance Association of New York State, as well as Consumer Directed Action of New York State, RC4. Visual description, I'm a white male, bald head, blue glasses, gray beard, wearing a white shirt today. I'm just going to go ahead and take a second to share my screen for folks, and we'll kind of get started as my slide deck loads. There we are. Too big to thrive. I think, you know, the basis as I've kind of looked into this and thought about this, and as I presented this, is, you know, in New York, we've gone through a transition in thought over the past number of years. You know, there was that period, right? When this program began in 1980 in New York City. In 1992, it moved from New York City to a state pilot program within Medicaid, expanding to Onondaga County, which, for those of you not familiar with the counties of New York, is essentially Syracuse. 95, it was adopted statewide. And between 1995 and 2011, the program grew to and then held at between 10,000 and 11,000 people. It was a darling of a Medicaid program. The Department of Health loved it. The Division of the Budget loved it. Democrats loved it. Republicans loved it. Everyone loved the Consumer Directed Personal Assistance Program, or CDPAP. In 2011, people liked it so much, they actually provided CDPANYs with a state grant to educate consumers and hospital discharge planners about the program and try to get more people involved in the consumer directed program, recognizing the value of the program, both from the philosophical standpoint, the dignity of risk, all of the pieces that we understand as values of self-direction, as well as the actual value and the cost savings that CDPAP represented to the rest of the state. And that's why when we moved to managed care in 2013, the state simultaneously published their Olmstead plan and noted that CDPAP participation would be identified as one of the quality metrics for managed care. Managed care plans were actively being told at this point, enroll people in CDPAP. That is the direction we want you to go. At this point in history, 2013, 2014, we gave the Department of Health an award for their commitment to self-direction, their commitment to the CDPAP program. This was that, sweetheart phase, right? This was, CDPAP was the darling program of New York's Medicaid. It was only then, once that direction came through, that opinions began to shift. You can see, you go from the origin story to the superhero always becomes the bad guy. That's a given of any comic book series. In 2017, you really began to hear rumblings in New York of CDPAP growing too fast. The program was out of control. You had what were being labeled as unethical providers. They passed an advertising law that required review by the state before any CDPAP advertising could be done. And that was actually ultimately thrown out. It was challenged on First Amendment grounds because while the state can say you can or cannot advertise, they cannot review your language in advance. They do not have the power to approve what language is being used. In 2019, they went further and looked to curb the total number of agencies that were in effect. At that point, they were talking, the language that was used on when it was proposed was, we're looking to go down to, several agencies, maybe one. They got mad when we noted that the state was looking to move to one FI However, we would routinely note you don't go out of your way to say maybe one unless you're moving to one. New York, for people's edification who don't know, has always had a large number of agencies. When it was just a county based program, there were probably about 70, 75 agencies that contracted individually with the counties, and then that expanded as the program grew and more people were moving into it. And we wound up somewhere between the realm of 400 to 600 different agencies, some of whom operate with 50 to 60 consumers, and some of whom operate with 10 to 12,000. Um, in 2020, we had our Medicaid redesign team 2.0. Our former Governor Cuomo was a real fan of these Medicaid redesign teams. He brought in the hospitals, he brought in labor, he brought in others to propose changes. And this time, CDPAP was identified right up front as the primary target of Medicaid redesign 2.0. They put in place eligibility cuts uh, for the program, looking at activities of daily living and limiting eligibility for the program based upon that. However, COVID-19 hit, and we those cuts still have not been enacted today because the the maintenance of effort clauses prevented the state from enacting those cuts that in a way that would have allowed them to. That is actually, some of you may remember, if you were paying attention, our former illustrious governor um, threatened to turn down the federal money that was instituted in one of the first COVID funding bills. And the primary reason he threatened to turn down the federal money was because of these maintenance of effort clauses that prevented him from cutting CDPAP. He was going to turn down billions of dollars in aid because he would be unable to cut CDPAP. That, as I said, those cuts were actually never instituted. The maintenance of effort did change the conversation for a number of years. We actually moved to an offensive approach where we were looking to shift the conversation. We fought with others to raise wages for workers in what we dubbed the Fair Pay for Home Care campaign. Had marginal levels of success with that. But then in 2024, the state targeted CDPAP once again and moved to a single FI, noting that in their mind it would save $500 million. Spoiler alert for later, it doesn't. But we can get into that more as we go. What happened? What happened to change that dynamic? I alluded to this before, but as managed care realized the cost benefits, they began dramatically increasing the promotion of CDPAP. The managed care companies themselves recognized that CDPAP was a way to bring in members and utilize a cost-effective service. They also figured out that with CDPAP was a way to get around the fact that their members often couldn't access traditional services. I think we've seen the home care workforce shortage across the country, and yes, that was hitting CDPAP, but because of the ability to hire family members, there was the impact was mitigated in the CDPAP program. And so plans could get around the fact that the licensed agencies just could not physically provide the services based upon the workforce that they had. And not only were they now able to provide the services and serve these members, they could do so at a lower cost. New FIs began to emerge. I said we went from about 70 to 75 to 4 to 600 over the course of this period because new FIs came forward, worked with the managed care plans to promote the program in a way that was mutually beneficial to the plan, to the FI, and ultimately to the consumers as well. I think, well, this is national. If anyone has vacationed in New York City and taken a subway, you have seen an advertisement for a fiscal intermediary in those subways. You have seen an advertisement for CityPAP in those subways, on those buses throughout the city. They are near impossible to miss. And so what you saw was what we had noted. Enrollment began to increase dramatically. By 2024, the Division of Budget, the Department of Health, and Governor Hochul's talking point was that enrollment moved to 1,200%. And I want to flag that. That was their talking point and their rhetoric. I'm not necessarily pushing back on it right now. But what that enrollment did was raise costs. But it also threatened a lot of the traditional power brokers. I think if you go back through the entirety of the era where CDPAP suddenly became the bad guy, you will see it was the traditional power brokers. It was the hospitals. It was some of those vested in the nursing homes and some of the traditional agencies that were the ones who were seeking to cut CDPAP because we were using more funds, serving more people. If we're serving more people, that means they're serving less people. And they didn't like that. We became what was viewed as an easy target for budget cutters. We did not have the political capital of the hospital association. We did not have the political capital of the nursing homes or 1199 or some of the others. We were viewed as an easy target. That said, the reaction here, and I put this in big, bold red letters, right? The reaction is contrary to the traditional New York position on Medicaid, right? New York has historically welcomed participation in Medicaid. We encourage people to sign up for Medicaid at every step of the way. What we see is New York likes Medicaid, and I think this is true of many states. There is an appreciation for Medicaid when we're enrolling people who have either high costs for a brief period of time, pregnant women, that results in healthier babies. That's a good thing. We can all, I don't think anyone on the webinar will argue that we shouldn't have healthy babies. But, the cost is short term. Otherwise, they want healthy kids. You might pay for a broken arm. Other than that, you're paying for a flu shot and a physical once a year. They don't like paying for long-term care. Long-term care is a long-time cost. They don't want those folks to get involved. As we look at this growth, it's important to note that as much as they were demonizing CDPAP, as much as they were demonizing the fiscal intermediaries, the eligibility was established by DOH. DOH's contractor, which is Maximus, who runs the New York Independent Assessor Program, determined whether or not individuals met those eligibility guidelines. The managed care plans, the mainstream managed care plans, and the local departments of social services established the plans of care and figured out how many hours people performed. The FI only came in at the end. Once that was done, they could alert people to the fact that a program existed, but they didn't enroll people. They weren't responsible for people coming into the program ultimately. They could just create awareness. And that awareness was largely based on need. And realistically, this is where we get into that 1200%, right? A report by the Fiscal Policy Institute, who I stole this chart from, showed that that number wasn't actually 1200%. That number was 3.9%. There's a difference there. Small, but it is a notable difference between those two numbers. And what is that? It's not you can't look at the growth of CDPAP or self-direction in a vacuum. We exist as part of the home care program within Medicaid. And what we could see is that, yes, CDPAP, which is that purple line, is growing. That's the total number of hours in CDPAP, and it's growing from 2018 to 2023. But the agency-based hours, those licensed home care hours, are shrinking at that same time. And so the total growth of home care was 3.9%. And in fact, if you look at this chart and compare the hours between the two programs and then the value proposition, the fiscal value proposition, New York actually saved the state $200 million in 2023 alone. And so it's really this kind of short-sighted, blinder approach to Medicaid fiscal policy that is driven by a division of budget or your fiscal division, as opposed to the state health department, as opposed to those who are responsible for policy and looking at a healthcare system overall. Because if you look at just the value of providing people with services who need those services, in a way that was consistent with the aging population in New York. And I think that's the key part, right? Like, I always go back to a couple years ago, one of the elected officials here in New York had commented that, you know, the baby boom generation is something we saw coming since the 1960s, late 60s, early 70s. We knew this was a demographic change that was going to hit, and that we were going to have to provide long-term care services for this demographic. The fact that at no point during the last 40 years did anyone actually do anything about that, 50 years, I guess now, did anyone actually do anything about that? That's a failure of government. It's not a problem that is the fault of the fiscal intermediaries or the home care agencies or anyone else. Like, the demand has been there and we've known it was coming. We need to figure out how we're going to handle that demand in the most efficient way possible. You know, I like to joke that the real reason New York, and this is a cynical joke, but the real reason New York is so angry at CDPAP is they had really the perfect program in that agency-based home care, in that they could offer this wonderful, generous home care benefit. But because of the home care workforce shortage, no one could actually use it, right? Like, if you can't supply workers, you can't, the program itself is worthless. CDPAP, in solving that workforce problem, at least partially, suddenly made the state actually provide the benefit it was so keen on offering. And they didn't like having to actually provide the benefit. They wanted to just offer the benefit. And you know, this all goes to this population, and this, most of you have probably seen some iteration of this chart over the years. If I were better with charts and graphs, I would have put little boxes or the like. But you know, the blue and red are your folks with disabilities and seniors. That's who's going to use your long-term care services. They make up, you know, about 20% of the Medicaid population here in New York. If you go over to the column on the right, um, that same population accounts for probably about 60% of the expenditures in the Medicaid program. This goes to what I had said previously. It's not a surprise to anyone. If you are on this webinar, you probably have an idea of this slide. I just wanted to kind of come back to that slide, though, regarding the hours, right? You can look at this and see, before the success of CDPAP, before that line started to grow, and you can really see this line continue down if you were to take it to 2017 and earlier. Agency-based personal care was the target in New York. It's not like long-term care, agency-based personal care was very popular and CDPAP came along and that was suddenly the problem. No, agency-based personal care was the subject of attacks right up until the moment CDPAP became the subject of attacks. The rise of CDPAP hours first threatened agencies and others who had organized the traditional agencies. And as CDPAP surpassed those agencies, they adapted. And the agencies began attacking CDPAP. So how did we safeguard against those attacks? We worked in extremely broad coalitions. So we brought together the strength of CDPAP or self-direction in general is really an empowered consumer group, an empowered group of people using the program. And that is a built-in strength that realistically no one else in the healthcare network has. You don't have hospital patients out there advocating for hospitals. Most LICSAs don't have their patients out there working for them in an agency-based home care model. The ability of those consumers, and we had providers, the FIs, consumers, and worker groups all coming together. We also added in Medicaid advocacy groups like Medicaid Matters New York. We have legal aid groups. We did partner with organized labor for a while. That changed recently. And we had parents and other allies who were partners with us. We built ties amongst the different communities and looked to break down some of the existing barriers that had been there in the past. The physical disabilities community, the developmental disabilities community, the aging community, and others who in the past had kind of fought for same pieces of the pie. We brought together to say, no, we're not going to fight each other anymore. We're going to work to improve this system for all of us because we all rely on it. We built ties with our elected officials and made sure that agency staff and legislative staff were invested in the program. We didn't, and don't forget your budget staff. They might be harder to convince at times, but if building out the economic value of the program as it relates to other long-term care programs and the healthcare system overall is of tremendous value. And if you are a state program on the line here, and you're looking at this going, how do I guard against folks in my administration from coming in as my self-directed program gets popular? You can engage in these things of your own, right? You go to your leadership in an agency, go to the division of budget as you are permitted, and present to them these arguments, present to them the value proposition and the like, right? Build those ties and make folks understand internally. You're actually in the best spot to be guarding against a lot of these cuts right up front. You can guard against the cuts before they ever see the light of day, before we in the community ever have to actually deal with them. And understand your value, understand the value of this program. Our value is, unfortunately, the value of this program is not in our values, right? Like we can all know that self-direction is the right path. We can know that self-direction is the way that services should move forward, that, the dignity of risk, the right to fail, the ability of folks to direct and control their own healthcare services is just in many ways a moral imperative. This doesn't win arguments. It's a sad state of affairs, but it is the real state of affairs. Calculate the real savings. Self-direction is less expensive than any other care, hands down. Calculate these savings using hard data and make sure everyone understands that value. If you can get data on potentially preventable admissions for the hospitals and how your version of self-direction works to prevent that, use that data. That just compounds, right? It builds in how self-direction not only saves long-term care money, but health system and Medicaid money across the board. Some of that data is harder to come by than others, but this all just builds out this argument. And understand how different players see your value, right? The managed care plans are going to look and see the value of self-directed in a much different way than state agencies. The legislature will look at it from a budget perspective and their constituents. And your partners in the community will all view the value of self-direction differently depending on what role they are looking at it from. Understanding that value and presenting the value of self-direction to folks the way they see that value, the way they perceive that value will build that strength and build those connections so that we can hopefully prevent up front, but definitely safeguard if attacks do come. And I would argue when attacks do come. Where does self-direction fit into the continuum of long-term care supports and services in your community? Is it one option? Is it the primary option? It is increasingly the primary option in a number of states. I know it did become that in New York. It is that in California and some other states. Should it be the primary option if it's not? Is there agreement among all of those parties that were listed before as to where self-direction fits into that continuum? And what should eligibility look like? These questions have answers. I have answers to these questions in New York that might not match Massachusetts or Minnesota or Wyoming or New Mexico. As pieces move forward, what, if any, cuts can you accept? Will you ever accept eligibility cuts, wage cuts, reimbursement cuts? And when you're asking this question of yourself internally, also be thinking about this and having these conversations with a broader community, right? If you've done your job and built those broader relationships to protect the program, if you're an agency and you say, oh yeah, we can accept eligibility cuts, that's not going to impact our bottom line, well, you're going to ruin your relationship with a lot of those consumer groups in all likelihood. Likewise, if you're a consumer group and you've built those ties up with the agencies and you have a really good relationship where each is fighting for each other and you accept reimbursement cuts, understand the impact that's going to have on that relationship. And then, are you solely focused on self-direction? And I don't mean this from your viewpoint. I mean this from legislators and executives. I cannot imagine this is something they like only in New York. They work from that, limited pie model, limited resources. Are you willing to accept that structure for the debate? Are you willing to accept the structure? Oh, well, if you want higher eligibility for self-direction, what should we cut? We have never been willing to engage in that. This really comes down to this old quote. I traced it back to a Roman general. I think it's been used and bastardized any number of times over the years, but if you want peace, prepare for war. Don't wait until the cuts come to put all of these different pieces together. Your odds are it's going to be too late. You're going to be trying to, build the net once you've jumped. Know that regardless of where things are today, cuts are coming. You work off the idea that at some point, probably in a future that is closer than further away, you will be facing cuts to your self-directed program. That no matter how good your relationships are, for those who are state entities, no matter how much you have done to build support internally, those cuts are coming. I cannot stress enough, don't wait until the cuts are proposed to build your army. Don't wait until everything is there. Understand your strengths. Who do your legislators and agencies listen to? Is it the consumers? Is it the workers? Don't put in New York, the legislature doesn't listen to the agencies. We know this. The agencies have value. They have value in a meeting. They can present a particular aspect, but the legislature cares about the consumers and the workers. Maybe in that order. So put forward the arguments that are going to be compelling, and then have consistent engagement and consistent communication with everyone, with those in the network, as well as your allies and opponents. Recognize that, this goes to that question. What are you willing to accept that, there is a limited pie? Divide and conquer is the oldest trick in a book for a reason. They will look to pit the consumers against the agencies, against the workers. That is, throughout history, the easiest way to win a battle. And it works very, very well every year. We pit healthcare versus education versus food stamps versus this versus this. The reality is, it's the same person. The person whose self-direction is being cut, if you say to cut the education system instead, it's probably the educational resources that person who uses self-direction relies on to go to school. There's probably rental subsidies they need in order to live in the community. There's probably heating assistance that's needed, right? Like, it's the same. Which part, the real question is, which part of my life should I accept being ravaged? Don't let your relationships break because you're willing to accept divide and conquer. Talk to each other. When these things come up and you're being told, oh, well, so-and-so said this, verify it. Don't just accept it. And if that is true, figure out how you can get around it without leading to a split. Most importantly, let them underestimate you. The first year we faced cuts back in 2017, they underestimated me to no end. They legit had one talking point. One week in, I knew what their talking point was. In newspaper articles, I was addressing their talking point in the first paragraph of a statement, and then 7 paragraphs later, they would issue their talking point and look silly because it's already been addressed three different ways above. Let them underestimate you. That only helps you win. Self-direction is not traditionally a power player. They will underestimate your resolve and your fight. They will think they're going to just come in and trample over you and you will take it. Why? They've always done that, right? They've always done that to folks with disabilities. They've always done that to the aging community. Be disciplined, stay united, be consistent, and their confidence will be their undoing. We have used this time and time again. I just want to give you a few things before I hand it over, right? Like, as we go 7 years of proposed cuts, we have lost a few fights over the years. Right now, we're in a massive fight for our life that we may or may not win. But, we have won more than we lost. As I said, in 2019, then Governor Cuomo His Department of Health and consultants in DOH proposed going to a few or maybe one FI. As I said, they had one talking point. We had a consistent message and we nullified theirs. Instead, there was a request for proposals process that was actually refined over several years. I told you the example in 2020 where Governor Cuomo, the hospitals, the union, and consultants in DOH again. Consultants in health departments are generally a theme, and recognize they may be your undoing ultimately. Consultants, one big, rapidly growing cost is an easy target for consultants who like easy targets. And most state agencies around the country are now populated mostly by consultants who make a lot of money off simple, easy solutions that don't actually address problems. They made CDPAP the villain of Medicaid overspending. They nullified the worst. We, again, nullified the worst of the proposals. There were the cuts to eligibility, but those still have not gone in because of those MOEs that are still winding their way through. 2023, we built and secured a lot more of those relationships. We used fair pay for home care to bring together workers and consumers, recognizing that you can have all the services in the world. If consumers can't hire workers, they're meaningless. We built wage increases, but built into that was the recognition that those wage increases mean the FIs have to pay more money. And when the managed care plans didn't want to get that money through, because the FIs were on the front line fighting with consumers and workers, the consumers and workers came back and were on the front lines fighting with the FIs to get the managed care plans to send that money through. Did it all come through ultimately? No. The managed care plans will usually get their cut. We did get a lot more of it than was initially proposed, though. Finally, we had last year, many of you may have seen some of this. It's been a high profile fight over the past year. They started out last year with proposed cuts to designated representatives, which in New York we have, and I don't know if every state has, but designated representatives run the program for a consumer if the consumer lacks capacity. So they're maybe under 18, or they have Alzheimer's or dementia or TBI. They've cut reimbursement. They proposed cut to wages after just increasing wages. All of the parties remained opposed and created a strong public groundswell. It was really a surprise bait and switch at the end, where, at the end of the budget, and according to court documents, the Assembly, the governor, 1199, and again, according to many reports, PPL proposed going to one fiscal intermediary. The last minute nature did in fact lead agencies to splinter. We lost a lot of that unanimity, a lot of that hard support across disciplines. Our message discipline suffered. Again, this was all proposed on April 2nd for a budget that was due on April 1st and passed on April 17th. So, it really came out of nowhere for us. And at the end of the day, in New York, 1199 is very powerful. They carried the day. We mounted a strong defense at that time. They carried the day. Over the course of the past year, we have continued up that fight. We are engaged in that fight today. Literally, there are groups out at the state capitol today working with allies in the legislature, working consumers, agencies, workers, all working together, pushing back against this cut, pushing back, highlighting how dangerous this is going to be. As of today, the governor is continuing on with the proposal, but it has gathered attention from both Democrats and Republicans, both at the state and federal level, and something that simultaneously pleases and terrifies me. This is a chart I prepared initially for different reasons, but I think it's worth note it here, right? This move to one FI is a cautionary tale. The state will say, we're not cutting eligibility, we're not cutting benefits. They're saying that it will save $500 million. But our estimates are that between the cost of people shifting from self-direction to agency-based care, as well as higher rates that are being charged under the single FI, the cost, it will actually be a $640 million cost, and that's the state share. So that's plus or minus 1.25 billion total, all funds. The savings come from consumers dropping off the program. On April 1st, that's 12 days from today, every FI in the state except for PPL will shut down. This past weekend, the Commissioner of Health said 100,000 of the 280,000 consumers had completed transitioning. That means 1/3 of the consumers. If the switch were to happen today, 2/3 of the people in the program would cease to be in the program. That's where the savings come from. Recognize that cuts don't always come from eligibility cuts. Cuts come through more insidious means that are designed to just have people drop off the program through means that they can then come back and blame on the consumers. We saw this last year in Massachusetts with some of the pieces around EVV. We're seeing it in New York. My guess is if I look deeper into different states around the country, we would see it time and time again. The cuts are not always blatant and forthright. You sometimes have to look a little harder and say, how is this policy going to just cause people to fall off the program? Because I'll tell you, New York knows how to do a transition. They did it at the end of the public health emergency. It was a 12-month planning process and an 18-month transition after that. They know how to do a transition and keep people on a Medicaid program. They made an active decision to engage this way. So that kind of wraps up the presentation I have for y'all. Happy to take any questions.
Thank you, Brian. Here is a question. Did the direct care agencies fight to stop self-direction in your state because they were losing money? Do these agencies or trade associations ever suggest an agency with choice model?
I'm sorry, I coughed and missed the very, very beginning of the question.
Oh, no worries. Yeah. Did the direct care agencies fight to stop self-direction in your state because they were losing money?
No, I think the direct care agencies have been fighting with us over the past year or two. I mean, that keep their ability to remain in business. The agencies themselves have not been the problem. I think there were divisions among some of those agencies as to how to go about any potential change or reform. But the agencies were always on board. The proposals to all of the proposals for cuts came from generally the Division of Budget, the Department of Health, and in this past year in particular, specifically the governor. In terms of an agency with choice, we do have that within our Office for People with Developmental Disabilities. I think within Medicaid, that is not something within the Department of Health's state plan Medicaid service, it's not something that the state's Department of Health has ever wanted to pursue. We had it on our agenda for a while. I think it is actually technically still there. We have just been engaged in kind of the defensive fights for so long that agency with choice and a pure budget authority has not been um, pursued with more vigor, largely because we don't have the bandwidth and the resources. I will say, in New York, we don't have agency with choice. We don't have a budget model. We don't have agency. We have a kind of weird hybrid model that developed because of, that demonstration program in New York City that went back to 1980. And it really is a hybrid model of different pieces that exist around the country. So it's got strengths and weaknesses, but I don't think realistically all of this is likely coming to the OPWDD budget model after this.
Thank you. Here's another one. What are some ways to show or calculate the cost savings of self-direction in a state? What specific data points did New York use to calculate and show self-direction provided a significant cost savings to the state?
I mean, the clearest was, and arguably the most simple, when we won the wage increase, we were able to see, and you can get, this is available via FOIL if you can't get it just in publicly available data, the amount that is baked into a managed care plan's rate for traditional agency-based care versus self-direction. And so we knew that, for agency-based care, they were paying X, and for self-direction, they were paying Y. And if you then are able to get the average number of hours, you just figure out, okay, this is the average number of hours. This is the cost difference. Here, it becomes subtraction. And so, that is the simplest way to get value proposition. Others are more abstract. It doesn't stop other entities from using them. I will say a lot of the research does not exist as much within the self-direction space. But if you can get data on, the use of hospitals or other aspects of the healthcare system from people who use self-direction versus people who are in a traditional agency-based home care or a nursing home or this, that, the other, right? Like those are ways that you can continue to drive value propositions. It requires some foils. It requires some research that at the very least is beyond my capacity. But those are areas for any researchers or academics who are on the line. Those are areas that are definitely potentially of value moving forward to the broader community. And there are definitely areas that if you have access to that data, either through friendly relationships with a plan or something else, you can really begin to spell out some of that.
Thank you, Brian. What strategies did you use to convince the traditional providers that they should value self-direction too, including creating allies?
Bluntly, as a child of the 90s, I'll go with my, continued, I will generally call it my Wu-Tang Clan theory on government, but this will be my Wu-Tang Clan theory on home care, right? Like cash rules everything around me. If you are a licensed agency who provides traditional agency-based care and you see that all the people are moving to this service, well, let me get in on this service, right? Like it wasn't always philosophical. I would like to think it was. I would like to think there was a broad philosophical underpinning, but I think a lot of times it was just, this is where the business is. I'm going, if everyone's going to start buying blue widgets, I'm going to stock blue widgets, right? If everyone's going to want self-directed care as opposed to licensed care, then I'm going to start providing self-directed care. And once they started providing it, they realized, wait, this is actually less expensive for me to offer. I don't have to hire nurses to oversee the personal care aides. I don't have the scheduling expense. I don't have um, all of these different pieces that I would have in my traditional agency. So, it became just a sheer economics argument for most of them. I wish it was values, but it wasn't.
Thank you. I think this next one is related to a potential slide they saw. So in New York, designated reps can be paid.
Designated representatives are not paid. The designated representative is typically a family member, a legal guardian, some sort of other individual who willingly takes on that role on a volunteer basis. The designated representative cannot work for the FI. And they cannot be the personal assistant or the worker. So, but it is a volunteer role. It is not paid.
Thank you, Brian. Here's another one. We are experiencing the beginnings of exactly what you described here in Maryland. If SDS saves money and provides employment for family members who otherwise may not be able to hold a job due to responsibilities at home, what do you think is behind this agenda to cut self-direction?
Um, I think, you hear a lot in New York about the family who is providing services. No official will ever say that they want to cut CDPAP because family is getting paid to provide services in public. Behind closed doors, they will most definitely say that. And what's behind it? Honestly, I think it's a sense of entitlement. It's a sense of a lack of awareness of real world situations. I had a health plan executive who will remain unnamed say in a private meeting, there's been a real breakdown in the family unit in some of those communities. If my sister or daughter needed services, I would provide them for free. Now, we can ignore the not so coded racism involved in that statement. And just go to the fact that no, he wouldn't provide them for free. This is an individual who makes in the high 6, low 7 figures. He would hire somebody through the gray market to provide those services for his daughter. If he did provide them for free, he is salaried in the high 6 figures or low 7 figures. And when he has to leave to go home and take care of his daughter because something happened, he's still getting paid and he can do that work at another time. It is a lack of awareness that, like, you leave your job at Target or Burger King or McDonald's or whatever, you're at best not getting paid and in all likelihood don't have a job to go back to the next day. And that, look, this is New York. Like, Manhattan's not cheap. Heck, the Bronx and Brooklyn aren't cheap. People have food. People have rent. They have mortgages, heat, all of these expenses. Last I checked, this is still a capitalist country, and people want money in exchange for goods and services. And CDPAP, self-direction, is a way to acknowledge that. I think there's a lack of understanding of that in the world. And, that is the basis for a lot of these attacks, but that is also, one of the keys that we need to overcome.
Thank you so much, Brian, for your expertise and your time today. As we wrap up, I want to thank everyone for joining us today. A quick survey will pop up on your screen following the webinar. I hope everyone has a good rest of your day. Thanks again, Brian.
Thank you.